tenemos tiempo para preguntas.
Dr. Schomburger, what would be your first choice in treating pain in elderly patients?
Good question. Elderly patients. I think elderly patients are just as needed of opioids as anyone else, but the difference with elderly patients is to start with a very low dose. So one of the teachings is that with pain medication, you want to be very careful with your dose in kids, in old people, patients with renal dysfunction, liver dysfunction. So in those patients, just start low and work your way up. So in those patients, reassessment is particularly important because we don't want to go on the high side, we want to start low and work up. But in terms of the choice of medication, it's the same as anyone else.
Jan, would you comment on, once you send the patient home, the fall, how you manage elderly patients in terms of their pain?
So the question is, when you send patients home, elderly patients in particular, what kind of approach would you use in terms of managing their pain? Elderly patients are more prone to have side effects from pain medications. We know this. Elderly patients are more prone to fall. They're more prone to complex constipation issues. And so managing elderly patients with pain can be a bit of a challenge. And we also know that they are often taking many other medications that we have to keep in mind. So it's important to look at an elderly patient's list of medications to determine the interactions and the things that they might be at risk for, and to maybe take an approach that's a little less aggressive as you discharge them. So I understand that here, not that many patients are discharged with opioids. You use a lot of tramadol here. And that's okay. We don't use as much tramadol in the United States. But treating elderly patients with things like acetaminophen, good. Be careful about putting them on things like NSAIDs for long periods of time. Ibuprofen, naproxen, they have kidney issues, they have other problems, so not a good idea for long periods of time. But they can go home with opiates. We just want to keep it a lower dose and give them a lot of education about the possible effects. Question over there, we have time? Yeah?
Here. One more question. Good morning. How do you manage, or what do you recommend for patients who go to the ER looking for meds who have a drug dependency?
Yeah. So the question is about the patients who come to the emergency department who have drug dependency issues. This is a very big topic and a very, very, very hot topic in the United States right now about dealing with patients who are coming and have drug dependency issues. We are starting in the United States to develop protocols and statements that the emergency department will not give prescriptions for patients with chronic pain, that they need to be having a primary clinician, a primary doctor, manage their pain issues. These can be real challenges, and the importance there, I think, is really about communication and talking to patients about their pain issues and listening to them, but also deciding for yourself what your own limits are and expressing those to the patient. So often what we don't do is really confront the issue in the beginning and set the expectations. What is it that you're here for? What can I help you with today? This is what I'm willing to do for you. This will be my limit, and that's when we're going to move on. So being very clear in the beginning what you're willing to do, what you're not going to do, and what the expectations are early in their visit. And that's probably one of the best ways to negotiate the situation. We're finding that if we create policies that are very explicit about what we will or won't provide as a department, sometimes that can help you avoid individual conflict. So if we say in our department it's just a policy that we're not going to do that, then sometimes it takes some of the pressure off you as an individual provider. But it's a complex question.
Despidamos a la doctora en Concepto 2014 de su última presentación. Muchas gracias, doctora, por acompañarnos este año. Nuestra tercera conferencia está a cargo del doctor Peter VICCELLIO, especialista en medicina de urgencias, Vice Chairman del Departamento de Medicina de Urgencias y Associate Chief Medical Officer del Health Science Center de la Universidad de Stony Brook, Nueva York. Nos va a hablar hoy día de tóxicos, algunos nuevos y viejos conocidos. Demos la bienvenida al doctor VICCELLIO.
Buenos dias. I wanted to add a very important thing about pain management that Jan did not mention, and this is based on a very new and very important study. Volunteers were asked to do the following. They take their fist and they put it into a bucket of ice water, and they stand there and they see how long they can take it. They stand there quietly and they measure the time before the pain is so excruciating they can't take it anymore and they have to take their hand out. So they measure that time. Then they take the same people and ask them to do it again. But this time, while their hand is in there, they are told, you can curse as much as you want. And by cursing, and cursing loudly, they were able to tolerate more pain. So my takeaway on that, when I'm about to do a painful procedure on a patient and they're not sedated, I ask them to curse as loudly as they can, to use as many bad words as they possibly can think up, and it'll make them feel better. Now, this is supposedly, the reason this works is because it increases your endogenous endorphins. And it turns out people who curse all the time, this doesn't work for them. So you have to not curse in your normal life in order for this to work for pain. So, and how they found out that this was, the endorphins were raised, I don't know. Somehow they got rats to curse and then they measured the endorphin levels or something like that. I don't know. Anyway, let's do it. I want to talk a little bit about some random stuff in toxicology. So here's a warm-up exercise. We have a gentleman that used to use narcotics. He says he doesn't use narcotics anymore, but he was found on a park bench with the following unusual findings: a respiratory rate of 3 and very tiny pupils. And what was interesting about him, though, is when he was brought to the emergency department, he had a large bag of poppy seeds with him. And so I'm sitting and, poppy seeds, you can get morphine from it, and I'm thinking, could this guy actually eat enough poppy seeds that he could get high from it? Doesn't seem possible. So we have a very, very smart person that works in our department. His name is, I don't know if you've heard of him, his name is Dr. Google. So I Googled poppy seeds and overdose, and I was very surprised. First off, you can get poppy seeds anywhere, but you can buy them online as long as you promise not to use them for illicit purposes. You can go to poppyseeds.com. So when I Googled, I found this case. This is a teenager that took a bunch of poppy seeds, and he made tea out of the poppy seed, and he was found dead in his room. And the coroner, they found the tea that he had made, so the coroner reconstructed based on the number of poppy seeds in there, made some poppy seed tea, and measured the amount of morphine that was in an 8-ounce cup of poppy seed tea. And it was, what he found was, it was about 0.25 milligrams per cc. So in an 8-ounce cup, that's about 60 or 70 milligrams of morphine. And so this guy that I had as the patient, of course, denied this whole thing. Oh, absolutely not. This is for Mom. She's going to make a lot of poppy seed bagels. And he denied it. A little later on, another patient came into that room that was also an overdose, a young woman, and who hit it up with, sort of got to know this guy, and they became friends sitting there in the room. And the nurse overheard him describing how to make the poppy seed tea to her. So now, I like to show videos where you can be medically challenged. So I want you to try to determine by this next video if you think this man is drunk. And he's going to be given a breathalyzer test. And as you know, a breathalyzer test, they give you this and you blow into it and it measures your alcohol level. So I want you to try to determine what you think. You may have seen this before, I don't know. So the police are there. They think this man's drunk. So they're going to give him the breathalyzer test. He's supposed to blow into it. So what's your vote? So at Stony Brook, we will see patients who come in and they've been drinking and they're also suicidal. So we have this protocol. Our psychiatrists say, well, we can't see them until they're sober. And I'll show you what happens as a result of this. But so they come in intoxicated, so they're throwing up and they're feeling terrible. And then the alcohol starts to wear off. And so now they're getting a little anxious. And of course, we have to wait for the alcohol to go down before the psychiatrist will come see them. So what happens next is that they start to shake and they're now really withdrawing. And so our protocol sort of guarantees that people are going to withdraw from alcohol. So we're going to take an intoxicated patient and now make them at risk for death because we let them withdraw. You can predict who's going to withdraw based on their alcohol level and how they're behaving at that alcohol level. An alcohol level in New York of legally drunk is 80 mg%. How would you get to that level? If you remember each drink, and it doesn't matter whether it's beer, wine, or a mixed drink, or a shot of scotch or something like that, you'll increase your level by about 25 mg% per drink, and you also metabolize 1 drink an hour. So if I see a patient with an alcohol level of 400, the way I would achieve that level is to have 17 drinks in 1 hour. I don't know how you would be after 17 drinks in 1 hour, but other than being covered in urine, I would be in a deep coma and you would have to put me on a respirator. However, if you see somebody with an alcohol level of 400 and they're talking to you, they are definitely going to withdraw when that alcohol level is off. And here's one study that shows the higher the alcohol level, the surprise, surprise, the more likely they are to withdraw. Why is this? My brain wants to be at a normal state of attention. GABA depresses my mental state. Glutamate enhances my mental state, is excitatory. So if I have too much GABA, then it makes me want to make more glutamate so that I'll be awake. If I keep drinking alcohol, then the brain says, oh, I don't need so much GABA because there's this other substance coming in that's making me sleepy. So I get less and less GABA, I get more and more and more glutamate. Now you take the alcohol away, and I'm overexcited, and that causes a withdrawal. So imagine somebody that never has had a drink. He has 1 drink. It may make him a little sleepy. It's like a dose of Valium, 5 milligrams of Valium. Might make you a little sleepy. Somebody who drinks and they can talk at a level of 400, think of how much Valium they would need to equate to that level of 400. And that'll make sense with what I'm going to talk about some things. So you can't fix stupid, but you can sedate it. And that's what I wanted to talk about alcohol withdrawal once you have such a patient, how you manage them. How many of you have used Valium or diazepam for alcohol withdrawal? And how many use Ativan? So it's a mix. So Valium is my drug of choice for a couple of reasons. Because it's stored in the fat. Although it has a short clinical half-life, it has a long pharmacologic half-life. So if the patient gets ignored, the Valium is going to leach out of the cells and back into the bloodstream and maybe help them. But how many of you who have used Valium have used in an hour period 200 milligrams of Valium in an hour? Has anybody ever used that much? Does that sound like a lot? Does an alcohol level of 400 sound like a lot if somebody's talking to you? So for the treatment goals, it's going to be the basics, support, all the supportive measures you need to do. You want to prevent them from getting worse. You don't want them to go from alcohol withdrawal to the full-blown DTs, because now you're talking about somebody who's much more likely to die. If they have an underlying illness, you've got to address that. And if you have the opportunity to try to break the cycle through rehab or something like that, that's all great. But right now, we're worried about the guy who came in drunk, he's now withdrawing, or came in withdrawing, shaking like a leaf, What are you going to do? So I recommend diazepam because of the reasons I've said, but if the person has cirrhosis, some argue this is the wrong drug to use, and you should use lorazepam instead, or oxazepam. Chlorodiazepam epoxide, or what we call Librium, I don't know if that's the same name that you use here, is sort of a standard mainstay for oral therapy to manage withdrawal. Phenobarb is a wonderful drug, and I'll talk a little bit about why in a minute. And then, of course, propofol is the final pathway to anyone that doesn't have egg allergy to just knock them out. So here are some things on diazepam you might find interesting in sort of world records. The highest reported dose of Valium in a 48-hour period was 2,540 milligrams. Anybody beat that here? No? 2,850 in 5 days. I had a patient, it was a guy in rapid AFib. He was an alcoholic. He was only a little shaky. His cardiologist was there and wanted to cardiovert him, so he wanted me to sedate the patient. So I used, at that time we were using Valium, so I gave him 5, nothing happened. I gave him 10, nothing happened. Another 10, another 10, another 10. 30 minutes into this, the patient had had 120 milligrams of Valium, was still wide awake. The cardiologist got angry, so he said, well, zip, and cardioverted him anyway, and he went back into normal sinus. So another drug to use is phenobarbital, and phenobarbital, some people use this as their primary drug, although there's very little literature on how this compares to our other treatments. But this is the second in line when what you're using is failing. And a couple of reasons that this is second in line is it binds different receptors than do the benzodiazepams. It enhances binding of the benzodiazepams that you're already using. So don't forget to use phenobarb as your second line drug. Bring it in when all else is failing. So how much is enough? However much the patient needs. Don't think about the milligrams you're giving. Look at the patient. If the patient's still wide awake, and you give them more, and keep giving them more until they are calm, almost on the sleepy side, and their shaking is much better. So I'm going to give you 2 methods that are out there. One is from Scott Weingart's website, emcrit.org. And another variation on this is published in a publication called Up to Date. And that comes out of from Bob Hoffman at Bellevue Hospital in New York City. And I'll just give you some notion of what the doses that are currently recommended for severe alcohol withdrawal. This patient's coming in, they're shaking like a leaf. Every 5 minutes, or every 5 to 10 minutes, you give a dose of Valium, and this is your dose. You start with 10 milligrams, then 10 milligrams, then 20 milligrams, then 20 milligrams, then 40 milligrams, 40, 40, 40, and if that doesn't work, now we got to get serious. So then you would go to IV phenobarb, and you go 65, then 130, then 260, and if that doesn't work, you just say, you know what, screw it, we're going to intubate the patient, we're going to put them on propofol, and really completely just knock them out. And then you can wean them off the propofol and go back to the diazepam. So method 2, which is very similar, except it pushes the Valium much further. So think of this. I want to ask anybody in the room if they've ever done even close to this. Every 5 minutes, I'm going to give 10, and then I'm going to give 20, and then 20, and then 20, and then 40, and then 40, and then 40, and then 80, and then 80, and then 80, and then 100, and then 100, and 100. And if you do that every 5 minutes, in that first hour, you've given a total of 730 milligrams of Valium. Your pharmacist had to come up with a big vat to leave at the bedside. You might as well just drown the patient in Valium if you're going to do this. If you've given that much in an hour, then you might want to consider you need something else. So that's my first tip to you today. If you give 800 milligrams of Valium in an hour and they're still dancing around your emergency department, think of something else. Do the phenobarb blow dart and hit them with that. So if they're resistant, and this is the definition of resistance, you would add phenobarb. So you may be adding phenobarb in the first hour. This is the way I do this in real life, is you're sitting in the bed and you're sort of shaky, and I give you the first dose of Valium, and what I notice a few minutes later is I don't think I gave you anything. There's just no difference. So at the 5-minute mark, I give you a higher dose. And a couple of minutes later, I look at you, Jesus, there's no difference. So I don't care what the dose is. What I care is, when is the first point at which I touch you, at which I start to see a difference? And that's the dose. Okay, I'll stick with that dose for a while. But my whole point in going through this is I hope to leave you, when you go back to work in the emergency department and you see somebody really shaking like a leaf, really think of much larger doses than you're used to and much more frequent doses. By the way, I forgot to mention, diazepam or Valium you can use every 5 minutes because you're going to see the effect in 2 or 3 minutes. That's not true with Ativan. That's really a 10 to 15 minute drug because it's a little bit more delayed, the effect. And so you may end up stacking too much. So I prefer Valium. I think it's a little safer. Again, if all else fails, you intubate and propofol. Librium is the mainstay of oral therapy. The typical dose is 50. I like to start with an oral agent at the same time I'm starting with the IV agent. And my dose of Librium for the last 5 or 6 years, for the first dose of Librium, has been 200 milligrams. I am rethinking that because I have never seen a patient look different after 200 milligrams. So I think maybe I'll go to 300 or 400, I don't know. But the dose of 50 is, you might think, to prevent withdrawal, but it's not going to manage withdrawal. It's not going to make the withdrawing patient better. I throw this as an oddball out there because if it may, from further research, actually turn out to be true. This is a study. We take a bunch of people who are withdrawing from alcohol and we give half of them oxytocin, intranasal oxytocin, and half of them don't. Oxytocin's a weird drug used for other things besides things having to do with deliveries and that sort of thing. Oxytocin, if you spray it in somebody's face, you know the effect? It makes them trust you. It has this neurologic effect. It enhances the trust factor. But in this, what they found was that if you gave them intranasal oxytocin, is it dramatically decreased the need for benzos to control the withdrawal. Whether this pans out to be true, I don't know, but it is so different and so unusual than anything else written out there. I just throw it out to you so that if the next article comes along that confirms this, then start to consider this as part of your armamentarium. So let's switch gears. I'm going to give you another case. This is an elderly lady that's brought in by her family. She's normally, she's a businesswoman, 72-year-old businesswoman, and has a very important, intellectually challenging job. And she comes in that for the last week, she's been progressively confused. She will get involved in a conversation and then it suddenly just doesn't make any sense what she's saying. She's not agitated, she's not trembling, she's not tachycardic, but she's just wacky, just sort of crazy. And she'll seem normal for a minute and then abnormal. Otherwise, she has a normal neurologic exam. One thing of importance was that in the last few weeks, she had been treated for a urine infection with Cipro. So what we were thinking is, oh, this is what the cause of her mental status is, because particularly in elderly patients, Cipro can cause an altered mental status. Nonetheless, I came on shift. She had been there for 18 hours. She'd been seen by the neurologist. She'd gotten the $1 million workup. She'd gotten CT. She got an MRI. Because her mental status seemed to be waxing, waning, there was a very legitimate concern that also this could be partial complex seizures. So an EEG was done, and the EEG didn't show any seizure activity. So the last thing to show, she was signed out to me is, we don't know what to do, why don't you go admit her? And I wanted to say, well, why didn't you admit her? But this is a trick you can use in emergency medicine. No matter what the problem is, order an amylase and sign it out to the next shift. But anyway, they signed it out to me, and I looked at this lady, and she was bizarre, and I said, you know, we do have encephalitis around here. She hadn't been febrile or anything, but I'm going to take her, and I'm going to do a tap on her. And she was pretty uncooperative, so I decided I was going to sedate her for the lumbar puncture. So how do you sedate somebody for the lumbar puncture? I used propofol. So, and the procedure took about 10 minutes. I did the LP, the fluid comes back clear, everything looks good. I finish, we let her wake up, and when she wakes up, she's 100% normal, completely normal. And in taking further history, it turned out that she ran out of her Xanax. And so she was completely normal. Or alprazolam, I don't know if you call that Xanax here, but in the States, this is a very commonly used drug for anxiety. And people will start at 0.25 milligrams. They'll commonly get up to 1 milligram. They may take 1 milligram 3 or 4 times a day. 1 milligram of this substance is the same as about 10 to 20 milligrams of Valium. And the withdrawal, when you read literature on withdrawal from benzos, they lump it in together with alcohol. And the syndrome is very, very different in benzo withdrawal. You can get seizures, yes, but they don't as typically get shaky, tachycardic, and those sort of obvious signs. I've seen 5 or 6 cases of this from alprazolam, which I think does this more than the other benzos, where somebody comes with just an altered mental status. They're starting to act crazy, and then it turns out that they stopped their alprazolam or they ran out of it. So always think of benzo withdrawal when people come in with recent onset, acting strange, and that sort of thing. So now let's move on to some completely different stuff. I want to give you a little potpourri of some weird stuff that's out there now. And the first, have you heard of crocodile? Yeah. So crocodile is this wonderful thing. You cook it at home. So it's home cooking. But the home cooking includes codeine and things like paint thinner or gasoline, red phosphorus, hydrochloric acid, and iodine. And that mix is what you're injecting into your skin. And the reason this is called crocodile is the first change in the skin is green, scaly skin. So you become looking like a crocodile. But you can also imagine that if I inject gasoline or hydrochloric acid under my skin might not like that very well. And what happens, why do you want to do this? This is in extraordinarily poor areas where they are addicted to the drug, narcotics, they can't get narcotics. And this, which is the result of that home cooking, is a great narcotic. It's a very powerful narcotic. So people shoot themselves in order to get this. It just came to the United States in the last year. There's been a couple of states where its use has been reported. I doubt you've seen any of this here, but this is how you're going to notice it. Imagine a patient comes to your emergency department that looks like this. This is not eczema. Or a patient that looks, I didn't believe this was real. So I looked around to see if I could find something a little bit better document. So, I'm not sure if this is a model or not. And I'm looking at this, I'm like, what the heck is this? Until he turns his head and looks at you. So he's going to look up now, he's going to give you a nice little smile. But this is not a happy camper. But this is the result of the, so all these sort of things that you see from the crocodile is just, it's disgusting, isn't it? Ugh. So a few other things that are seen, bath salts, I'm sure you've are all familiar with. This is these are synthetic cathinones. They are both stimulant and hallucinogen. There's no particular special antidote for it other than sedation. This is symptomatic treatment if you see patients in the emergency department and you just sedate them. So let me just run through these. This is the zombie. This is sort of the internet. I love the internet because all this weird crap gets out there on the internet. So now it's, you become a zombie by bath salts. And this was the famous story that was in Los Angeles, where this is a homeless guy who was attacked by somebody who supposedly was on bath salts. Of course, the story actually turned out to be this was a chronic schizophrenic that was untreated that attacked this guy, chewed up his face, and this is how he looks afterwards. He looks actually happier in this picture than he does in that picture, doesn't he? And even to prove it to you, here he is. He's actually playing the guitar now. So you know, I don't know if you're familiar with Dr. Huffman. Dr. Huffman works at, I believe, Wake Forest in North Carolina. And his claim to fame is that he studies marijuana and tetrahydrocannabinol, and he has synthesized 400 congeners that bind to the THC receptor. So they're marijuana mimics. But because they're mimics, they may have, depending on the drug, a marijuana effect, they may have a stimulant effect, or they may have an hallucinogenic effect. So how does this get out there? This gets out into the population by a thing called K2. And what K2 is, I'm going to take anything. I'll take oregano or parsley, and I'm going to spray it with one of these substances, and I'll sell it as marijuana, but it's one of these 400 substances. So you don't know when you're about to smoke it, are you going to get high and want to eat and sleep and laugh? Or are you going to have a trip? Or are you going to, is it going to be like taking cocaine? So this is what K2 is. It's you take any sort of spice and you spray it with this liquid, and that becomes your K2. So please spray my cigar, and there I am in Cuba, and we are we don't know if we're going to get high or what. And this is just a gratuitous picture of somebody smoking along with their friend, and it has no meaning whatsoever to the point of this talk. Salvia divinorum is a very popular thing. The plants that it comes for are very nondescript, so it can't be legally controlled very easily. This, by report, gives a wonderful, smooth, brief trip. It's really nice. How many of you want to try it later on today? So everybody in the back's raising their hand, in case you can't see up front. So this binds the kappa opioid receptors. It's non-serotonergic. You can smoke it, ingest it, take it under your tongue, have it as a tea while your friend's having poppy seed tea, or drink it or put it in alcohol. It's actually legal in the United States, and it's not federally controlled in the United States. There are a few states that have laws against this. I do want to show you some laws from Los Angeles, but I want to point out that I'm from New York. So reportedly 6% of high school seniors in the United States have used salvia, and it's a nice short trip. If you want to talk about a long trip, a trip that lasts for a couple of days, there's a substance called bromo dragonfly, and the reason it's called dragonfly is because the molecule itself, the compound itself, is sort of shaped like a dragonfly. So it's a nice long trip, often an unpleasant trip, but the other effect of this substance is vasoconstriction. So this has been something that's the result of the use of dragonfly, is vasoconstriction of the peripheral vessels and loss of limb as a result. But speaking of trips, and I think you mentioned, or one of you mentioned this in a lecture last week, another very nice, smooth trip, if you look on Arrowwood, one of the best you can have. By the way, this sign is in Spanish when you're not looking. So if you look away, if somebody look away, and then you look back, it's in English again. So the Bufo alvarius, everybody familiar with this? This is the Colorado toad. So it excretes a toxin on the back of its neck, which is hallucinogenic. And so people say, well, what you're supposed to do is you get the toad, and you threaten it. And that makes it really excrete a whole lot of stuff on the back of its neck, and then you lick it. Actually, if you do that, there are too many toxins there. It can cause seizures, and that's actually a very dangerous thing to do. But if you scrape it off and dry it, and then smoke it. I don't want to give you too specific instructions here, but if you scrape it off and you dry it and then you smoke it, it gives you this very short, very pleasant trip. Highly recommended. So that's the Bufo alvarius. Here's where you can order them. And they arrive with instructions like keep them away from your dogs and children and stuff like that. And you can get a video on how to extract the toxin. This is on YouTube. Very useful stuff on YouTube, but just don't lick it. It's bad, bad, bad. So here are some laws in Los Angeles. For instance, you cannot bathe 2 babies in the same tub at the same time. That's against the law. Dogs cannot mate within 500 yards of a church. I don't know how they enforce that law, but they do. But in Los Angeles, it is against the law for you to lick a toad. So but you can come to New York and do it. That's okay. And this is actually a 57 or 26 kilo frog, which that'd be a little bit too much toxin to smoke, I would think. Another drug, this is, the devil's breath. This came out of, news stories came out of Brazil, and of course on the internet, people get to say things and they become fact. So here was the fact. Everybody familiar with scopolamine? And you could put it in somebody's drink, and then they develop the anticholinergic crisis, main part of which is that they're very confused and they don't know what they're doing or where they're going. And so whoever drugged them now can take their money in their wallet and this sort of stuff. Well, there were reports from Brazil that you could just take the powder and blow it in somebody's face, and now you had total control of them. There's a couple of problems with that. If you can blow it in somebody's face, then what happens if you absorb it through your palm? Or what happens if you breathe in before you like, so that's a bunch of BS. But here's all these news stories about scopolamine, and there's all sorts of plants that this can come from. Devil's breath, brugmansia, the Jimson weed we see a fair amount in the United States, and angel's trumpet. And it gives you the Alice in Wonderland syndrome or the Charlie Sheen syndrome. And physostigmine's a nice antidote from this. You take a crazy person and you make them normal just with 1 injection of a milligram. Khat is something that's commonly used in Africa. It's sort of a nice version of cocaine, and that's starting to come over to the States much more. I don't know if it's made it to this area or not, but it's sort of a natural bath salt or stimulant. It's a cathinone. And everybody's happy having this stuff. These are all nice pictures here. King Tut used to chew on this stuff. We know that because he left a little diary. Had a nice bit of cat today. Now I'm going to finish with something that's all natural. I like stuff that's all natural, that you can do at home. And you don't have to go out and grow plants illegally or whatever else. All natural. Look at this. You can make this yourself, all natural. This was first reported in some very impoverished areas of Africa. Jenkem, the master drug of the new era. Your own feces and urine, fermented in the sun for a week. You inhale it and sniff it, and you can see your dead relatives and see the future. How wonderful. So this started with some reports from BBC in Africa and ended with some YouTube videos from Texas where, as a spoof, some people pretended that they were doing this. But the idea is that they take sewage with stool in it, they put it in a plastic bottle, cover it, and let it sit for a week. You'd always want it to sit for a week. You don't want to sniff it too early. And then they would inhale it, and I guess probably the methane gas or something gave them a problem. And if you need the recipe afterwards, we can talk. Jenkem, and there's all this sort of goofy stuff here now. I think it's pretty disgusting, but this is something that you can do at home and then do a YouTube video for everybody to appreciate. So I don't do drugs, I am drugs. And I do want to take, I'm sorry to take the next person's time, but I do want to take 1 minute to talk about a very special overdose, aspirin. Somebody comes in and they put 300 aspirin in their stomach, and you start treating them. You give them charcoal to prevent further absorption. You may want to gastric lavage them or something else. When you have a very serious, dangerous overdose like this, you may want to think of that. One thing to know about aspirin, and this has been reported a number of times in the literature. We had 3 cases in 1 year of deaths from aspirin overdose because of one particular reason. Patient comes in, aspirin overdose, we give them charcoal. Charcoal prevents the absorption of the aspirin level starts to come down, patient is now fine, we stop treatment. transfer him to the ward. 12 hours later, the patient's found dead in bed. On autopsy, a bezoar of aspirin is found in the stomach. And this can happen with a number of drugs, but it happens commonly with aspirin, where as it starts to melt in the stomach, it forms a baseball. And so you only absorb off the baseball. As long as you give charcoal, you prevent that absorption. Once you stop treatment, you got this huge loads of aspirin that gets ingested. So always worry about that with aspirin. Once you think you're done, continue to track the aspirin overdose. On that note, I want to thank first Bill Mallon for suggesting that I come down here and participate with this wonderful group here. And I want to thank you, and it's been a lot of fun being here. So who's next?